Sincere thanks to cACLD-II team for giving me an opportunity to present the topic Predictors of Treatment Response to AKI-HRS. So I'll discuss the topic under these headings. Now just to give an overview to the residents here, cirrhosis has two important components, portal hypertension, and as portal hypertension versus there is gut congestion, bacterial translocation, nitric oxide, etc. leading to splanchnic vasodilatation. This portal and splanchnic would cause systemic vasodilatation, in effect decreasing the effective plasma volume, decreased GFR, renal vasoconstriction. Here with renal dysfunction, you have ascites and formation and all the complications associated with ascites. As the disease progresses, it can be hydrothorax, dilutional hyponatremia, refractory ascites and HRS. The whole thing is in a continuum. So we have important pathogenesis issues that are there. There is splanchnic vasodilatation, bacterial translocation, effective hypovolemia, renal vasoconstriction causing to fluid retention and organ damage. So in effect, with progression of disease, a euvolumic state becomes a hypovolemic state without actual blood loss because of vasodilatation. This decreases MAP, renal perfusion, and GFR. So it's a circulatory dysfunction with persistently decreased effective blood volume causing low MAP, renal perfusion, and GFR. That are the key things. Now as it is a dynamic state, no two people with HRS would be the same. Some person can come with creatinine of 2.1, albumin of 3.1. Some can have a creatinine of 5 with albumin of 2. So the degree of hypovolemia is separate. Hypovolemia or underfill hemodynamic deficit is separate for everybody. Some may require small push, some may require a bigger hemodynamic deficit to overcome the problems. Once AKI develops, we all know the 30-day and 90-day mortality. The key is to identify early, treat early, so that within the first week or so, if we are able to reverse and have complete recovery, the prognosis is much better. Here comes the role of predictors of HRS-AKI. So coming to the impact of hemodynamics, studies, dopamine stress echo studies in HRS have shown that these people have lower cardiac output, lower stroke volume, and delta change in heart rate is lower. In effect, these people have low cardiac reserve, and with low cardiac reserve is associated mortality associated with this disease. So lower the reserve, the poorer the mortality. So this emphasizes the role of cardiac reserve in mortality that is not related with the, we are not talking about the CTP or MELD or bilirubin score, it's just the cardiac reserve that is predicting mortality in patients with refractory ascites hepatorenal syndrome. A recent study from PGI Chandigarh group showed that evaluation of 30% rated patient outcome in HRS, mortality was based due to presence of cirrhotic cardiomyopathy. The worse the degree of left ventricular diastolic function, the higher the mortality. This was based on 30% response to HRS-AKI patients. So cirrhotic cardiomyopathy and reduction in cardiac index predicted 30% non-response in HRS-AKI, and cirrhotic cardiomyopathy was independently associated with much poorer survival. In this same study, they gave predictors for 30% non-response, and all these were echo findings, E by septal defect, delta cardiac index change at 72 hours, day 3, serum biomarkers done at day 1 and day 0 and day 3, and they were significantly significant to suggest response to 30% and survival. What is the issue of baseline evaluation? How significant are they? We have seen that if higher the creatinine, poorer is the survival. Creatinine of 3 compared to creatinine of 5, significant difference between survival is there. A very simple bedside marker is urine output. With your treatment, urine output is not improving. Person obviously is struggling to get. A urinary tool NGAL has been pretty common, but not very commonly available in most centers in India. So NGAL could differentiate HRS, HRS-AKI, ATN versus other forms of AKI. and an NGAL of 220 was shown to be significantly up to 90% sensitive and 80% specific to predict response to terlipressin in HRS-AKI. So we could also differentiate between the types of AKI, and the response to terlipressin could also be judged. A very simple marker is MAP, and it's very commonly, I find it very useful commonly to predict the prognosis once you start the treatment. Studies in cirrhotics have shown that MAP of 83 or above, these patients rarely present or develop ascites compared to people with MAP of less than 82. MAP more than 80, the autoregulatory renal blood flow is very good compared to MAP less than 80. So renal blood flow is so important for ascites and all its complications to development. Now a pooled analysis of clinical trials of vasoconstrictor in HRS has shown that as the MAP increases on therapy, the creatinine level decrease. This is a 7-day change in MAP comparing MAP change with creatinine change. So rise in MAP with HRS therapy associated with improvement in AKI and survival. Another simple study is renal artery resistive index. So renal artery resistive index, as you know, there is decreased renal blood flow, RA-RI goes up, GFR comes down, and RA-RI has been shown to increase as the severity of ascites increases from diuretic sensitive to diuretic refractory, and RA-RI is inversely proportional to urine output. Now RA-RI is inversely proportional to the filtration fraction of the kidney or the GFR. So as the RA-RI goes up, GFR and filtration fraction comes down. So important component is to simple tool on Doppler to look at the RA-RI and see if it's improving with therapy. So in a recent study published this year itself, high RA-RI independently predicted mortality in AKI patients with cirrhosis. It was found to be higher to the tune of 0.78 and above, which predicted mortality. RA-RI could also differentiate between the types of AKI, AKI-ATN, HRS-AKI versus other cause with a good sensitivity, specificity and AURAC of more than 90%. Again, the recent study done this year, published this year, showed the improvement in delta RA-RI with treatment. Here the red line shows change in MAP with terlipressin in HRS-AKI patients. Change in MAP of 10.4 or above at day 3 was significantly correlated with survival. The other issues were inflammation at day 1, rise in MAP and delta RA-RI change. Delta RA-RI change of 5% or more predicted improved survival and recovery from HRS-AKI on terlipressin. So this is the same study showing improvement of delta RA-RI by 5% at day 3. So early predictive models between day 3 to day 4 suggested improvement of renal functions and survival. Now once we start vasoconstrictors, what is the response to vasoconstrictors, and obviously complications associated with terlipressin. We need to identify them first and tide over that to improve survival. Confirmed trial published in 2021 gave a window for terlipressin to come to US, and that has been going on now. Before that it was not very commonly available. The confirmed trial did show terlipressin is useful in HRS-AKI. The problem was increase in intravascular volume overload and respiratory disorders, respiratory failure in patients going on ventilator. So a significantly high risk of death because of respiratory issues, volume overload with confirmed trial. The confirmed trial showed, compared the patients who did well versus patients who did not do well. Again, the main issues was MAP. The mean arterial pressure significantly improved in patients who did very well. It also reaffirmed the importance of improvement in hemodynamics. The GFR and renal functions and MAP improved simultaneously. So these are very simple markers, MAP and hemodynamic assessment. The complications are prevent intravascular volume overload. So this again they mentioned that diuretics may need to be initiated or continued if there is evidence of volume overload. This is a very important point that is commonly missed in treatment of HRS-AKI. So when to start terlipressin, early or late? Do we give a 48 hours volume expansion with albumin challenge or consider it early? As we showed previously, it's patients come with varying grades of hemodynamic deficit and no two people are same. So one of the studies published from our center, we had a response guided combination of albumin with vasoconstrictors and diuretics. Here we looked at the improvement of urinary sodium. We kept at urinary sodium of more than 80 millimoles per day with an RARI and MAP improvement. And we started early within 6 hours after doing an echo, getting the baseline evaluation done, and started early with that. So at 96 hours, that's on the right hand side corner, patient who could achieve a urinary sodium of more than 80 millimoles or simple urinary sodium, spot urinary sodium by potassium of more than 1 at day 4 had significantly higher survival. Up to 90% of patients survived if they had achieved a urinary sodium of 80 millimoles or more within day 4 compared to patients who could not. At day 7, if they achieved, survival came down to 30%, and patients who could not achieve urinary sodium of more than 80 millimoles at day 7, none of them survived. So a simple tool to assess, prognosticate at day 4. It helped mobilize ascites, gut congestion, bacteremia, endotoxemia, permeability came down, cytokines level came down, there was improvement in gut permeability, improvement in endotoxemia, and there was a linear correlation between endotoxins and permeability. So at the gut, as the gut congestion came down, endotoxemia, permeability came down, reducing the inflammation and SIRS component further, and also reduce the risk of secondary bacterial infection in our settings. Recent study from published this year from the ILPS, they also said eat early study where they gave terlipressin at 12 hours, and they also showed higher rate of AKI reversal at day 7 and day 14 compared to patients who received terlipressin after 48 hours. Here the same study showed that significant 28-day and 3-month survival in patient getting terlipressin early within 12 hours compared to patient getting terlipressin after 2 days. A recent study published from Gangaram group looked at the change in delta creatinine at day 4. Here they had 114 patients treated with terlipressin and albumin, and they came out with a Delhi model score, which I'll show in the next slide. And they showed that if the Delhi model score that was based on delta creatinine was less than 1, the survival was significantly better. They had 60, and the response to terlipressin was much higher. So this is the delta model that they predicted, that basically had day 0 creatinine and day 4 creatinine in the CTP score, and delta creatinine less than 1 had a significantly better survival compared to delta creatinine in patients who were having their Delhi model score of more than 1. So take home messages, very important to look at simple things like MAP, urinary sodium, urinary output. Systemic renal hemodynamics are important clinical predictors for response to HRS-AKI. Higher creatinine, higher urinary NGAL, worse outcome. Act early, may consider adding vasoconstrictors early, it is a potent strategy. Response guided therapy may help because no two patients with HRS-AKI would have same amount of pathophysiological dysfunction. It may vary. The role or the dose has to be altered with, complications have to be tidied up, and diuretics may have a role to mobilize fluid and prevent complications further. Thank you.